Welcome to Forward Physio, the show that gives you high-quality information about injury and rehabilitation, performance, and health. I am Noah Mandel, and I'm a physical therapist in Toronto, Canada. The purpose of this podcast is to give you educational content, not medical advice. So if you are dealing with a health-related concern, please take it up with your healthcare professional. If you enjoyed the podcast, I would really appreciate it if you'd be willing to leave a review. It takes 2 seconds, and you would be doing your part in helping the podcast grow so that we can provide this information to more and more people. Thank you very much for listening, and I hope you enjoy. Hey everyone, welcome back. I had a very, very special guest on the podcast today, and it is Stephanie Filbay. One of the most popular areas right now in physio is ACL Rehab, and this idea that ACLs can heal naturally. And Steph has been at the forefront of a lot of the research in this area in recent years. She is not just a researcher, though. She is also a physiotherapist and also sustained her own ACL injury when she was 18 in the past. So, needless to say, she has a lot of experience in the ACL world from many different lenses. Today on the show, we discuss the nature of ACL healing, what rehab may look like without getting surgery, and importantly, the new cross-bracing protocol. This is a protocol that patients can do shortly after sustaining an ACL injury that may make healing even more likely than it would naturally without any bracing. Steph was the lead author on the first paper published on the cross-bracing protocol, and she is working on a ton of different stuff so that we could elevate our knowledge in this area going forward. This is an awesome episode, and Steph did an amazing job detailing where exactly we're at in the landscape of non-operative ACL care. So, without further ado, I hope you enjoy. Okay, Steph, thanks again for joining me. I'm really excited to learn all things related to ACL healing and the cross-bracing protocol today. For those who don't know you, and if you're a clinician potentially having living under a rock, because I think your area is one of the most popular ones in the world of physiotherapy right now. So for those who don't know you, would you mind just giving us an introduction?
Sure, thanks, Noah. All right, so what to know? I'm a physio by background, so I completed my physio degree in 2010. I then did a PhD on quality of life after ACL injury, which I finished at the start of 2016. I went over to University of Oxford for 4 years and spent some time in Sweden and Denmark, and then came back to Melbourne, where I'm originally from, well, near Melbourne anyway. And I've been there for now 3 years, where I'm working at the University of Melbourne, looking into research on still outcomes after ACL injury, but looking at interventions to improve long-term outcomes. And comparing outcomes between people that have surgery and non-surgical treatment strategies as well. That's where I'm at the moment. So I have experience into ACL injury research, also some experience managing people as a physio, and then I have my own experience having had my own ACL injuries as well over the years, and revision surgeries and other things. So, yeah.
Is that what sort of set you on this path of studying them so much, is your own injury?
Yeah, I think so. So I was 18 when I first ruptured my ACL. That was my first year start of physio school at the time.
Oh.
So it didn't impact my decision to go into physio because I was already in it, but that may have put me down the research path into ACL injury. Yeah.
Okay. What a weird time to get injured, the start of physio school. You probably were swarmed by all these different opinions about how you should go managing it. But at the time, I wouldn't think that this idea of healing it conservatively was a viable option in your mind, was it? Or am I mistaken?
Exactly. So I remember what I was told at the time. So I went straight to see a surgeon. He was quite a well-known and popular surgeon. And one of the first things he asked is, do you want to go back to sport? And I said, of course I do. He's like, well, there is another option if you're happy just to run in straight lines for the rest of your life. And I said, of course not. I want the best treatment. I want to go back to sport. And it was sort of depicted like that. So what that does, it doesn't make it a hard decision because there wasn't a decision really.
Hmm.
For me, the way it was presented was that surgery was needed if I wanted to go back to sport. And
Yeah.
I was playing soccer at quite a high level at the time. So that wasn't really a question for me. So yeah.
Yeah, I still hear that all the time. I work in a sports medicine clinic, and I see a lot of people coming off of ACL surgeries, or they just got an ACL tear, and they're talking to surgeons, and I still think that information is being spread. That if you want to return to sport, you have to get a surgery. But would you say that's
Yeah.
the case?
Yeah. So we just surveyed almost 800 patients with ACL injury in Australia and a lot of physios as well. And we found that 90% of them had been told by a surgeon that if they want to go back to sport, they should have surgery, and that's the best
Wow,
option for returning to sport. And 60% of physios told that to patients as well.
really?
So it's interesting if you look at where that belief comes from, because there's no difference in return to sport rates when you compare management with rehab alone with surgery. So it isn't return to sport rates that's driving that belief. And it isn't re-injury rates either, because the evidence isn't there to suggest you have a higher risk of re-injury if you don't have surgery either.
Hmm.
So, it's been around for a long time, that belief, but it isn't actually supported by the available evidence at the moment.
Where did it come from, that belief? How did we get here?
Yeah, interesting. I mean, I don't know. We could sort of speculate. One thing is that surgeons typically see quite a biased sample of patients. So that the patients that come back to surgeons that say haven't had surgery, historically, let's say 10 years ago, they probably haven't had great rehab, and maybe they were misdiagnosed and tried to go back to sport and injured their meniscus and cartilage. So they're likely to see the worst case scenarios.
Mm.
Who they're not likely to see are the ones that are doing really well with rehab or return to sport and never had an issue. So they're not seeing them come to them. So if surgeons are historically driving that belief, it's probably based on the patients that they see, which is quite a selective group that are doing the worst, I suppose.
Yeah, that makes a lot of sense. Um,
Yeah, yeah.
yeah. So I want to ask you, at this point in time in 2023, is it controversial to say that with 100% certainty that at least in some people, ACLs can heal?
Um, so the word heal is, it's still a weighted, it's a word that some people don't like when it comes to the ACL for some reason. So we need to be very cautious, like much more cautious than we are with other ligaments.
Hmm.
With imaging in other ligaments, if you saw it was completely ruptured and then the appearance had normalized and it was continuous, you wouldn't question using the word healed. But when
Mm-hmm.
it comes to the ACL, we'd be kind of extra cautious, I think. Because one thing that's becoming apparent is that there's a continuum of healing, which there probably is for all structures in the body. So
Yeah.
it could, so if, yeah, so I'd ask what you mean by healing. If what you mean, is it possible for it to return to normal appearance on MRI? Then I'd say yes, it is.
Mm-hmm.
But I'd also say there's another spectrum of healing where the ACL rejoins, and it could be thinner than before in a certain portion. It could be looking a bit stretched and elongated, could
Mm-hmm.
be a bit thicker, or it could be completely normal. So, what we don't yet know is how the variations of what we're seeing in MRI could relate to variations in knee function.
I see.
Yeah, so the evidence we have at the moment suggests if we put all those together, all those with a continuous ACL, that they seem to be doing as well or better, as we found in the Canoon trial, compared to those managed with surgery.
Right. Okay.
So, yeah, but if we tease that out a little bit, it could be that the ones that have a normal appearance are doing extremely well, and then the elongated or some of them aren't doing that well. So, over average, they're doing better, but it's still a bit of a mix in terms of the different levels of healing that you might see.
And even if on an MRI it appears, fully continuous and appears pretty normal, that doesn't necessarily mean it has the same structures as the original ACL, right? Before the tear.
Yeah, so that's what we don't know yet, and it depends. like, what's your comparison, right? So if it's a graft,
Yeah.
I know which one I'd rather go with as a patient. If I could have my natural ACL tissue that appears healed on MRI compared to a graft and the rest of the trauma that occurs during the surgery, the
Mhm.
drilled tunnels and the graft site morbidity, and then tissue which essentially is typically a tendon and not a ligament in itself and screwed into the bone. So if that's your comparison, even if the structure and function isn't as it was pre-injury, which we don't know yet, I would hypothesize that it would be more similar to graft tissue if it's got that normal appearance on MRI.
Right. Right.
And it may
Yeah.
continue to remodel. Who knows the timeline, right? So the graft remodels over a period of years.
Hmm.
And maybe it's a similar thing with the ligament. It could take longer than we expect to normalize if it does. So I will say the best sort of evidence we have at the moment to go by in terms of the function is self-reported knee function from patients. And in the Canoon trial, yeah, we found that those with a continuous ligament reported better sport and recreational function and better knee-related quality of life at 2 years after injury compared to the reconstructed groups or those with a fully ruptured ACL.
Hmm.
But the reason that's an interesting group is because they weren't aware of their healing status. So that couldn't have
Uh,
sort of influenced their responses. Um, so in the bracing protocol, which I'm sure we'll talk about, people are aware of the healing status. They've sort of shown their MRI and they get that feedback saying, oh, you haven't got a great heel. It looks a bit thinner or a bit elongated. And then if you ask someone, how confident are you to play sport? Or, or how would you rate your knee confidence, which is one of the 4 items in the COOS quality of life, then they're probably going to be like, oh, it's not that great. I don't have a great heel because they've been told that.
right.
So these are the sort of things we need to tease out in research. So it was really surprising that they were doing better than the surgical group. I don't think we expected to find that in the Canoon
Hmm.
trial when they weren't aware of their healing status.
Yeah, it's really interesting. And if you have a surgeon telling you that this is the thing that you need in order to get back to playing sport, that might also affect your confidence in a more positive way, right? Gives you a little more buy-in for the
Absolutely.
surgery.
Yeah, definitely. I mean, there's a lot of contextual and placebo factors around surgery, naturally.
Yeah.
It's the nature of the intervention being very invasive, and often patients' perception is that I'm going to go get it fixed. And they talk about, oh, my ACL's fixed. If you talk to patients and they have a graft rupture, they often think that they're in the same situation when they initially injured their ACL, as if they could go down the non-surgical route and they're in the same situation. So they say, oh, now I want to manage my ACL non-operatively. It's like, well, you don't have an ACL anymore. It's been removed. So even that understanding that it's actually removing the ACL and replacing it with graft tissue, I think a lot of patients don't have. They think it's being fixed, it's being repaired, it's being reconstructed. Um, so yeah, I think it's as clinicians we need to sort of set more realistic and accurate understandings around both treatment options and around the pros and cons of each option.
Yeah, yeah, I agree. I we'll get into the cross bracing protocol in a little bit. But when it comes to someone re-tearing their graft, do we know if it's possible for that to heal naturally at this point? Is it possible? I don't think I've ever heard or seen or read of any research about that, but is that possible in your mind?
So yeah, we don't know. There's a lot we don't know actually about management options for someone that ruptures their graft, because one thing we know is that people that have revision surgery have really poor long-term outcomes. There's a lot of
Hmm.
evidence showing that they have a really high risk of osteoarthritis, chronic pain, symptoms, poor quality of life, poor physical activity in the long run. And then 27% will go on to rupture that graft another time and undergo a second revision. So it's a really bad position to be in. We really want to prevent someone being in the position where they rupture their graft. But yeah, do I think a ruptured graft could heal? I think probably not, but we don't know. It's not, people aren't being re-MRI'd at that point. But in saying that, a large number of people do go on to have revision surgery. And I've never heard a surgeon say, that they've, operated and found that it's rejoined. So
Right.
I've never heard that personally. I don't know anyone that has. I'd be interested to hear if that's the case. Yeah, because it isn't as the native ACL tissue. So
Yeah.
yeah, but there
I
is a
guess
lot.
just
We do need a lot more research in that area. I'm contacted by a lot of people that say, can I manage it non-operatively, my graft rupture? And I'm like, oh, there's no evidence to sort of show this is what your outcome might be like if you don't have revision surgery, or if you do once you're at that point.
right. And I guess just because of all that ambiguity that exists, if you do re-tear your graft, it just adds to the idea that it's a very big decision that people have to make after they tear their ACL, because there's consequences down the road depending on which pathway you decide to take. So do we have to, as clinicians or as patients, does that decision need to be rushed? How much time do we have to sort of decide if we want to do a bracing protocol, manage it conservatively, get a surgery?
Yep, that's a really good question. So if we put the bracing protocol aside,
Yeah.
uh, I'd say it doesn't have to be rushed. I reckon in a lot of cases, starting rehab for up to 3 months can be a really good option. And that's because prehab before surgery can improve surgical outcomes. So allowing your knee to come down, getting strength, getting proprioception, balance, etc. work in. Pre-surgery can improve your surgical outcome. But then we know 3 months seems to be long enough in which we're seeing who goes on to have some healing. So whether the ACL is going to be continuous or not appears to be apparent as early as 3 months after injury.
Mm-hmm.
And that also kind of aligns with the timeline that we were seeing in people trying rehab. Like typically you try it for at least 3 months, and by then you can start to see if there's good signs that, hey, this knee looks like it might become stable and this person might regain really good function. And that may be actually associated with the healing status of the ACL, which we don't know because that hasn't been considered in terms of predicting who goes on to cope or do really well with
Right.
rehab alone. Now, if we bring in the bracing protocol, we do think that's time sensitive. So from what we're seeing, to benefit from that, principle of reducing the gap distance between the ACL and immobilizing the ACL, there may be a kind of critical window after acute injury. And we think that's probably up to about 3 weeks, maybe 4 weeks. But after 3 weeks, you start to see some people who present, and on MRI, the ACL's rounded over and kind of capped over and retracted a little bit.
Mm.
So that might be similar to what you see when there's a non-union of a bone fracture.
Oh.
So it could be that those ends of the ACL have been separated for that length of time with the knee motion, and that healing hasn't occurred, and you can start to see that already. There's a lot we don't know about this, so there's been exceptions. There's been a few people that say, look, I know I've been told that, but I want to try the brace anyway, and then they've had a good heal anyway. But we think it's much less likely if it's, after 3 weeks, definitely after a month, maybe too long to wait.
I see.
To benefit from that sort of theory around reducing and immobilizing. So you might as well, if you want to go down a non-surgical route, try no bracing and rehab if you've waited that long and you have that appearance on MRI.
Mm-hmm. If you have that appearance of the ACL
Oh, that retracted and rounded up. That's what, like, involution of the ligament. That's what we think we're seeing based on clinical practice, where there's now been 500 patients managed. But we haven't looked at this statistically yet. So we're planning a study where we're looking at predictors of who's most likely to heal with the brace and who's most likely to heal with that optimal normal appearance heal. So we're running those stats at the moment, and there does seem to be relationships between certain things you see on MRI and who's most likely to go on and have a really good heal.
I see.
So yeah.
Are there other factors that might be involved in what may dictate whether or not someone heals well, besides maybe that time frame before bracing? Is there anything, I guess, that you would keep in mind when it comes to somebody saying, I want to try the conservative route, and you may think, maybe you're a better surgical candidate because I don't think healing is likely?
Yeah, exactly. Yeah. So that's something we're looking into at the moment. And it may end up being around the severity and nature of the ACL rupture. Not the location of the tear, so not where necessarily the tear is along the course of the ACL, but in particular whether there's any whether the ACL's been pulled off the bony origin, the femoral origin. So if it was a full avulsion and it had been completely pulled off the femoral footprint, we haven't tried to brace anyone with that characteristic, and I probably wouldn't. But the partial avulsion, so where part of like one of the bundles or part of the ACL has been torn off the femur, we think that they're going to be more likely to heal with a thinner or elongated, which makes sense. So that bundle that's been pulled off isn't likely to reconnect to that bony attachment. We've seen one or two instances where it has happened and it has reattached to the bony attachment, but again, we think it's much less likely. So in the first 80, that paper we published, 1 in 5 that had that optimal heel did have a partial avulsion, but the proportions of the partial avulsion was like, I believe it was 8% compared to that around I think 8% compared to 83% had their femoral origin intact. So those that achieved an optimal heel, 83% had that femoral origin intact. Those that achieved a suboptimal heel or no healing, only 8% had that intact. So we're running now some regression modeling to look at that and to with a larger number of people to understand that relationship a bit more. And the other factor may be the degree of disruption of the rest of the ligament. So sometimes on MRI you can see like the distal remnants flipped and it's sitting anteriorly into the intercondylar notch and it's displaced outside the intercondylar notch. So we think the degree of displacement as well may have something to do with healing potential. And there's a lot of potential here, I think, for like AI and machine learning techniques, to kind of identify some of these patterns of what we're seeing on MRI and then match that to healing outcomes as well. So hopefully that's the future. Yeah.
Yeah, I would say that would be fascinating, and I think it would make things a lot easier on you as well.
Yeah, exactly.
Okay, are there any demographic factors there? So those were all factors about the nature of the injury itself, but does age play a role? Does
Yeah.
health?
Again, a bit premature because we're running the analyses at the moment, but with age, we're not finding that younger age has a increased risk of healing. If anything, it may be the opposite direction where older age is associated with increased healing. But again, very preliminary, so we'll wait till we publish these findings. But we're also looking at things like hypermobility, the mechanism of injury, family history of ACL injury, and some other factors like that. So hopefully we'll publish that. We'll publish that in 2024 at some point.
Yeah, I'm looking forward to it. But until then, there's lots of grains of salt that should be taken with everything when it comes to all these healing factors. It's just we don't seem to know enough yet, right?
Exactly. So there's a couple of things to be aware of. Like, I think people are now making some clinical decisions around what they think may be associated with healing potential, but we don't know yet. And when we talk about healing potential in itself, we're kind of talking about the potential for a continuous and a thickened heel at 3 months compared to a continuous and a thinner or elongated heel. So that's what we're talking about. We're still talking about the ligament being continuous in both cases. And if you look at the PROMs that we reported in the recent paper, the patient-reported outcomes, even in those with a thinned or elongated heel, they reported really good or excellent knee function at 12 months. And I believe 66% had returned to sport by 12 months. And so we don't yet know how those with a thin or elongated heel may actually compare with those having surgery. It's possible that that's a comparable outcome. What we're seeing is it's a bit of a mixed group. So some do really well, just as if it was normal heel, and others don't and go on to have surgery. So I think if we tell someone, hey, we think you're more likely to have this elongated heel, so this isn't a treatment for you, I don't think that's really, that's doing the patient a bit of a disjustice as well. It should be
I
sort of
see.
informing them, acknowledging all the limitations we have at the moment and the extra research we're needed, and then explaining what we don't know about the different grades of healing. And then that decision, of course, is theirs to make, because the main
Yeah.
downside is inconvenience. It's mainly inconvenience in the brace, and
Right.
3 months is probably what you try anyway with rehab. So some people may still want to go through that treatment, even though it's potential that they have a less chance of getting this optimal heal on MRI. So there's a lot of unknown factors at the moment.
Yeah, totally. We've been teasing the brace a lot, and I think it's almost time to get into it. So I apologize to all the listeners that are eagerly waiting to if you don't know what the cross bracing protocol is, to really understand it and sort of know about its origins and how it actually works. I just have one last question about those patients who would never experience some healing. So you look at their MRI, 3 months, 6 months, 9 months later, and there's no healing. Is it possible for those people to have good outcomes? Is it possible for those sorts of people to return to sport? Or would you say it's better to have at least some healing or surgery or fully healed ACL, at least on MRI, as opposed to not having one at all?
Yeah, so that's a really good question, right? So all the historical research we have looking at rehabilitation compared to surgery, we've always just assumed that there's no healing of the ACL. It's a big assumption that's been made over the years. So we know that there's a lot of research now showing that on average outcomes are similar, whether you just have rehab or have early surgery. There's 2 clinical trials showing that, and this is with acute injury, 2 clinical trials showing that, and also many systematic reviews. However, that's just not even looking at the healing status, right? So, yeah, so now we flip that on its head and say, well, God, it's likely that there's a proportion of those that have had natural healing, and we don't know who they were. We don't know if they're doing better than the rest. Based on our Canoon findings at 2 years, it suggests maybe they were doing better, because they were at 2 years. That was the finding of that study. But there's still a lot of unknown. So we're looking at the longer term outcomes from the Canoon trial now, because we need longer term outcomes. Something we see after ACL injury when we start looking at outcomes 15, 20, 30 years down the track, they seem to kind of even out a bit. And I think part of the reason there is, so many people get osteoarthritis and osteophytes, and the knee gets really stiff, and they have potentially reduced function in terms of knee pain and stiffness, but there's no longer much knee instability.
I see.
So that may be why, you don't see like a lot of knee laxity 20, 30 years after ACL injury.
Right. That makes sense.
So if that makes sense. So we need to look a lot more into long-term outcomes. I wouldn't be surprised if those with a good heal are doing much better than everyone else, but we don't know that yet. We just don't have the evidence. I don't have the research available yet to look into that.
It seemed to be the case, at least in the short term, being, I think it was a year or so in the cross bracing protocol, that those with better healing seem to do a little bit better. And I think this is now finally a good time to get into it and discuss the bracing protocol. Hey, physios. I know that we all know how expensive continuing education courses can be. What if you had the chance to learn from some of the brightest minds in the industry from the comfort of your own home, all at the fraction of the cost of those weekend courses? This is where Masterclass by Physio Network comes in. Imagine having front row access to the world's leading experts breaking down complex topics into digestible module-based video courses. It's basically like Netflix for physios, and it gives you the option to learn about a ton of different topics. If you're interested in a particular area, the chances are that Physio Network already has a masterclass on it, or they're working on one right now. Masterclass is your ticket to staying relevant, informed, and delivering the best care possible to your patients. Click the link in the show notes and use the discount code NOAH10 at checkout to get an exclusive 10% off on Masterclass. Don't miss this opportunity to elevate your expertise. If you're still unsure, test it out with a 7-day free trial. You're going to love it. So my first question is, what is it and how did it first come about?
Sure. Okay. Maybe I can answer those two questions at once. So how it first came about was a very experienced and recently retired orthopedic surgeon based in Sydney, Merv Cross. He was actually doing rehab after double total knee replacement at his son's sports med clinic. And he had the curtain shut, was doing rehab, and I had overheard a conversation that his son Tom, who's a sports doctor, was having with a patient who had ruptured their ACL and really didn't want surgery. And they're saying there has to be another way. I don't want to go down surgery. And Merv opened the curtains and popped his head in and said, "Well, I think there is another way. You know, when back many years ago, we used to put people in plaster after their ACL surgeries, and we used to put them in flexion because that's when the origin and insertion of the ACL are closest together, and to try to help the graft to heal. Like that's when the ligament is most lax or most loose." And so basically this patient agreed to a completely untested treatment, which was to wear this brace in 90 degrees of knee flexion. So the protocol is wearing the brace in 90 degrees of knee flexion 24/7, all day, every day for 4 weeks. And then at weekly increments, it increases in terms of knee range allowed in the brace up until full range of motion at 10 weeks. And then the brace is taken off at 12 weeks. So this first patient had tried this brace and then had this, ideal grade 1 heel on MRI at the time that the brace came off, and they were shocked and surprised, So, and then the next patients that had come along over the course of the next few years were people sort of known to them. It was, I think there was a receptionist, son or daughter, the nephew of Tom, like family friends that'd be like, "Hey, we want to try this, and we've ruptured our ACL." And then sure enough, they had, excellent heel, and great outcomes. And so it was really those initial pioneering patients, if you will, that were happy to try something with no evidence and untested that started this idea up. And since then, Tom in his clinic in Sydney has now managed over 500 patients. People have undergone the bracing protocol in 10 countries, and New Zealand's one place where there's been quite a few people managed as well. So it's kind of snowballed and taken off, I think, as an idea, but that's how it originated. And describing the protocol, a couple of things to be aware of. It's a multidisciplinary team that delivers it. In particular, you need a doctor, often a sports doctor, but it could be a GP or a surgeon involved in the care who helps to screen for a DVT and a DVT risk, because you wouldn't want to brace someone with a high risk of DVT. You wouldn't want to immobilize them with an acute injury. And then people have DVT prophylactic medication, so that's really important for safety. And that's sort of the key role of the doctor, but you also need a radiologist who can read ACL rupture, ideally at baseline, and to help interpret the outcome as well. Mm-hmm. And then a physio who's delivering the rehab, modifying the brace, having weekly consults whilst the brace is being adjusted, and then a physio who's experienced in delivering, high quality rehab to get them back to sport. Yeah. So they're not inactive during the brace; they're doing as much as they possibly can within the available range, even whilst fixed at 90. So in the BJSM paper that was published in July this year, we have an appendix where we outline the entire protocol that the people underwent, including the rehab exercises at each phase and the goals of each phase whilst in the brace, and then once the brace is removed.
Yeah. What a fascinating origin story of it all.
Yeah.
And the paper, it's open access, right?
Yeah.
Okay. So you were saying that the decision to get into that brace after surgery, it has to be, or at least we think, a fairly quick one, at max about 3 to 4 weeks. I'm in Canada, and a barrier that I foresee is that here there's very long wait times for MRIs. Would you advise people could potentially try the cross bracing protocol without getting that initial MRI? Is that a good idea? What do you think?
Mm. Yeah, so I think here, like Tom, in my opinion, may differ a little, coming from
Yeah.
different angles. So,
Yeah.
me being a researcher and Tom being a clinician managing these people, um, because Tom would say, I believe Tom would say, no, we need this baseline MRI to try to understand who's most likely to have this ideal heel.
Right.
What I would say is, if they were informed, there's so much we don't know yet. We're not able to predict yet who will go on to heal and who won't. So if the patient wants to do the brace and we don't know the kind of injury they have, they're still going to have a potential for healing down that route. But the downside is that inconvenience or that potential that, hey, at the end of 3 months, you may have a longer heal or maybe no healing, and then you may go on and be recommended surgery.
Right.
And some people will say, well, I'm willing to take that risk. I'm willing to take these 3 months for the chance that I may then go on to avoid surgery and have good knee function. But yeah, I think it's too early. We don't have any accuracy in terms of being able to predict yet based on the MRI. And that's the main reason for that MRI. Of course, you could, as long as you have the DVT prophylactics, you could start the brace whilst waiting for an MRI. That's another option.
Yep.
Yeah, but still, unless there's going to be a full avulsion, there's just so much unknown that I don't think we can. I still think it could be beneficial. Take, for example, another country where they don't have MRIs at all, potentially, or somewhere potentially lower health resourced. I think that most people could commence the bracing protocol without a baseline MRI. But hopefully the research that will come out in 2024 might help us understand a little bit more about the likelihoods, and then we can inform people as well. So maybe we can say, hey, your likelihood of achieving a heel like this is this much greater with an injury like yours, for example.
Yeah. And I guess the more images and the more data that's gathered, the more informed we can make, or the more informed that decision is, and especially with the help of AI, that could really help as well. I could see that being very useful eventually.
Yeah, exactly. Yeah.
So obviously the major risk, as you've discussed, is DVT. Let's say someone tries the cross bracing protocol, and after 3 months, there hasn't been any healing, and they're recommended to get surgery. I'd imagine that after all that time, although it is a pretty active process and you're still doing exercises, there's still a significant amount of immobility, and overall, I would expect the leg to be a little bit atrophied. So at that point, I would imagine that you would advise them to take their time before getting the surgery and to really focus on their prehab and getting their strength up before doing the surgery. Would that be correct?
Yeah, that's a good point. So in some people, not a lot, we do see range of motion deficit, so a bit of a flexion contracture. I believe it was 14% of people in the first paper, or some muscle atrophy, some muscle activation issues at the time that the brace comes off. That seems to have resolved quickly for everyone. So in about 3 weeks, they had resolved those issues. From the patient's perspective, those that have had surgery previously on their other ACL before undergoing the brace seem to think it was much easier to regain strength, function, to return to sport in terms of the muscle strength and atrophy and that side of things. So that's a really interesting group to learn from. So now we've got over 60 people that have had surgery on their other leg previously and then undergone the brace for their opposite leg.
Yeah,
And we've done a qualitative study around that as well. So we'll hope to publish that soon, looking at people's experiences. Um,
that's
yeah,
exciting.
so yeah, so if they're one of those individuals who did have a range of motion deficit or some muscle atrophy or activation issues, I wouldn't want to have surgery whilst they're still there. I would wait a couple of weeks for those to resolve and then go into surgery at that point.
Oh, so it could be a pretty, it could be that they go into surgery pretty quickly after getting out of the brace then. You just a
Yeah,
few weeks to make sure that the range of motion and the strength is cleared up, and that's typically something that we advise most of the time with people that are undergoing this ACL surgery, right? Is that they have quote unquote a quiet knee, so like not a ton of
yeah,
symptoms, full range of
yeah,
motion, good strength.
exactly. And in a lot of cases, that is the case when the brace comes off because they are active and they have had that full range since 10 weeks.
Hmm.
They're weight bearing, they're doing a lot of rehab, a lot of strength work, leg presses, etc. So um, it's more the people that perhaps are a bit hesitant whilst in the brace and then they come off and they hadn't been using that full range available within the brace or they hadn't been loading perhaps as much that may have that risk and that lag in terms of regaining strength and control and other things.
Yeah, interesting.
Yeah, so yeah.
So they get their full range of motion at week 10. Is that also when they begin walking, or can they start walking before that when they're in the brace?
Yeah, so they're walking before that, usually from the week 6, around about week 6. It's as long as they can put their leg down safely. It's just about walking safely. It's not about avoiding weight bearing. So they're
Okay.
still taking weight through the leg in rehab. For example, wall squat holds, even at 90 degrees, bridges, other things, putting weight through the leg, but it's just in terms of safety and getting around.
Mm.
People opt to use like a knee scooter or an eye scooter for mobility. Some people use crutches. I think crutches is most challenging when you're still at 90.
Yeah.
If you can get your hands on a scooter, people seem to like that in terms of getting around. Um, yeah, so you can walk earlier once you have enough range to do so safely.
I see. And then, but as you mentioned, you could do wall squats. What at week 0 at the 90 degrees? That's so
Yeah,
interesting. Wow.
yeah. So wall squats, a lot of isometric quads and hammies, neuromuscular e-stims, whilst at
Hmm.
90. But you also working your hips, your calves, contralateral side, upper limb a lot, and still doing cardiovascular work with your upper limb and things. So
Right.
they are really active, these people, and doing quite a lot of rehab.
Yeah, that's great. When it comes to blood flow restriction training, we tend
Mm.
to use that early on in ACL rehab or just after different, surgical cases when people can't load very heavily, but we want them to get a good exercise stimulus. We could apply blood flow restriction training, and that could give them a pretty good training stimulus. Is this contraindicated in the case of the cross bracing protocol, or is it something that you've done with people?
No, so it hasn't been done. To my
Hmm.
knowledge, no one has tried that. So we don't know, and I don't know enough about it to know whether it could impact the tissue's ability to heal either. It's
Ah,
only temporary blood flow restriction, right? So it's
right.
it's alternating between the two states, but um, we tend to think blood flow is important in terms of facilitating the
Yeah.
inflammatory response and healing. Not saying that would impact it. I have no idea, but that would be something to look into, I think. It's such a new treatment. There's so many different elements we could study, right? Like
Yeah.
modifying the length of bracing, modifying the position, something like that, adding in an additional PRP injection or a blood flow restriction, or there's a lot of different elements you could look at tweaking to see if that makes a difference.
Yeah. It's such a new area. Are there other teams working on this, or is it just yours right now?
Um, just our team at the moment on this particular bracing protocol, but there has been other bracing treatments tried over the years, generally in extension, so like the opposite of what we're doing in flexion,
Yeah.
where we believe the ACL is actually more likely to be separated in that position. So and other people that have tried certain braces with a spring like a jack brace
Yep.
as well. And some people have braced in more like 30 degrees, 15 to 30 degrees of flexion. So there have been other bracing studies, usually quite small numbers, and often include some people with partial tears, which makes it a bit hard to differentiate the outcomes when some have partial and some have full tears.
Yeah.
Because, we expect most partial tears to heal anyway.
Right.
But there has been other people that have tried different bracing strategies over the years.
Okay. Yeah. So I wouldn't imagine that the blood flow restriction training is the most important thing to study right now. I think there's so many other research questions that need to be answered, and a big one that we've discussed is who is what sort of people are good candidates for the surgery. You mentioned if there's other ways that we could potentially try the bracing protocol. And you've mentioned some studies that are coming out in the next year. But after you've answered those questions, do you have an idea of where you want to go when it comes to the research? Yeah.
Yep, sure. So we've got 2 grant applications. So unfortunately in research, you have to get funding to do the big studies, and a lot of funding. They're really quite expensive. And that's highly competitive as well to get the funding. But put in 2 grant applications to 2 separate calls for multi-site, multi-state, so more Australia-wide clinical trial that would compare this bracing protocol to early ACL reconstruction.
Okay.
So we'll hear the outcome of one of those in the next few weeks, I think, and then the other one early next year. And then the other trial that I'd like to do is that one would be within a private sector in Australia, where around 75% of ACL injuries are managed privately. So people have sports insurance or health insurance or pay for the surgery themselves. Mm-hmm. But in the public sector, people actually go onto a wait list, and they wait around a year, but up to 3 years, especially in more rural areas. It can be a 3-year wait for ACL reconstruction. Wow. Where they're receiving nothing. They're not even receiving rehab whilst on that wait list. So they just get put on it and they're sitting there waiting for their surgery.
Oh my gosh.
So within the public sector, I'd like to then randomize people coming to this wait list to receive the bracing protocol or the usual care. You could also have an arm that receives quality rehab. But I think that's a really interesting design, because then we could actually compare rates of healing between the bracing protocol with a comparison group that's potentially doing nothing or doing some rehab.
Yeah, wow.
Yeah, and we could also look at surgical rates. So then I'd assume, the rate of people going on to have surgery would be much lower in those undergoing the bracing protocol whilst on the wait list.
Right. Wow. Yeah, a lot to look forward to then. And I really appreciate all the work that you're doing, because as I said at the start, I really think it's one of the most interesting areas right now. And a big part of it is a lot of the research that comes out in physiotherapy. It's rarely groundbreaking. And this cross bracing protocol, I think it's sort of changing the landscape a little bit, or at least how people are viewing the landscape. So first off, well done. Second off, thank you for doing all of this work, because I think it's incredibly impressive and important.
There's a lot of long-held assumptions when it comes to ACL injury. And I think challenging those assumptions, or at least questioning them, and then looking into the evidence and saying, actually, do we have the evidence to support this assumption? And in this area, the answer to that is typically no, we don't. So then to try to generate the evidence to challenge some of these assumptions, and that will start to flip some beliefs on their head and really inform future management of people going forward.
100%. Speaking of management, and instead of going forward, going back, it's a bit of a personal question, so I hope you don't mind. But if you can go back to when you were 18, would you try the cross bracing protocol?
Yes, absolutely. I think I would have tried rehab even before healing was part of the picture. Had it been offered to me as the evidence suggests today, I think I would have tried that first.
Yeah.
And I have done so for a lot of other injuries I've had. I recently injured my shoulder actually dislocated it, and a Bankart lesion, Hill-Sachs
Oh, wow.
lesion, and a severe labral tear. And I was recommended surgery, and I was told that, there's a lot of certainty in the evidence. Surgery actually does really well in these cases. It's a lot better than rehab. You're not going to heal without it. And being slightly biased by my work in the area of ACL, I said, that may be the case, but hey, I'm just going to try non-surgical first. And if I don't achieve the function I need, which I do want, I want really good function, but I'm at least going to give it a go to heal naturally and to have a successful outcome. And then I know I can always go and have surgery. So here I am 4 months after injury without surgery. My function is really starting to improve, but I don't know yet. Stay tuned to see if I go on to need surgery, but I'm going to try that first. And that's just the way that I am with most injuries, actually. Unless there's really good evidence for why I need this early surgery straight away, I'm going to try non-surgical first, and plan B is surgery.
Yeah, and I'm the same way with myself, and I think it makes a lot of sense. As long as there's not a strong indication for that early surgery, I would much prefer the non-invasive route, and there are higher risks with the surgeries. And it's not to say that everybody needs to think that way, right? But I think that's where being properly educated as a patient and making an informed decision comes into play.
Yeah, and whether there's some sort of genetic or personal factors that contribute to the way people respond to orthopedic surgeries. Because you see some people, they've athletes that have had 8, 10 surgeries, and they're doing great. Their joints look great, their function's great, there's minimal swelling, they do really well after surgery. And then other people who, once they have any surgery, their joint's really grumpy. It's swollen, it's painful, the function never really gets back, the muscle lags there, the neuromuscular control issues. And they do seem to be the same kinds of people that don't do well with surgeries or do quite well. So we don't understand a lot around that yet, but it could be something in relation to, the inflammatory response and other things that could genetically differ between people.
Mm-hmm. That's interesting. I've never thought about that before. Hopefully AI could help us out with that too, with sequencing the genome and then figuring out who's a good candidate.
I'm sure within the next, 50 years, we'll just get our genes tested and, a robot to read our MRIs, and then we'll go down the correct treatment pathway.
Yeah. Until then, even being in Canada and being, someone who probably couldn't get an MRI right away, knock on wood, but I think if I was to ever tear my ACL as well, I think I would heed the advice that you gave earlier, which is just I would try the cross bracing protocol, because understanding that there's no rush to get an ACL surgery, and it seems like there's not a lot of risks as well. With that said, do you think there's any caveats that you want to give to people at the end of this podcast? So wrapping up here, people may be very excited about this protocol, like myself. But I guess, are there any warnings that you might give before people eagerly try this if they are just coming off of an ACL tear?
Yes. So one would be following the protocol we have evidence for at the moment. So, for example, if a physio was perhaps delivering it incorrectly, or was immobilizing people and not doing the rehab, or wasn't doing the DVT prophylactics, which is critical, then it would be quite unsafe. We've found when people are taking the DVT prophylactic, it's been safe. But without that, it can put someone at risk of a DVT, which we definitely don't want. So I guess one of the risks is executing it properly, even having a well-fitted brace that's comfortable. And so being experienced or knowing how to deliver it properly is important. Other risks? Not really. I mean, there's some indications in cases where it's not appropriate. So if someone cannot be immobilized at 90 degrees for 4 weeks because of lifestyle, maybe they've got caring responsibilities, perhaps they have to work and they can't drive in that position. So there are some situations where we'd screen people and it's not an appropriate treatment for them. So it isn't for everyone. We try not to brace within the first 4 days because there's still that acute hemarthrosis and swelling, and it was quite uncomfortable for that person as well. So you wouldn't put it straight on, fixed at 90 degrees from day one.
I see.
People with an MCL rupture, a complete rupture of the MCL. So there were quite a few of them in the first 80 that we braced. And although they had quite good outcomes, they were really stiff at the time the brace came off because the MCL is in a shortened position and can heal quite shortened and be quite tight. So they're a group of people who now are receiving a more modified protocol, just to try to, so accelerated and not fixed at 90 for as long, to try to reduce the likelihood that they'll be quite stiff when the brace comes off.
Have you found that comes at the cost of ACL healing?
Good question. So we've now had over 80 people that have gone through a modified protocol. So some, for MCL rupture, but others because of lifestyle factors. They said, hey, I want to try this, but I really can't do it for 12 weeks. So I really can't do it at 90 for these reasons. So now there's 80 of them. So the more data we get, and the more data we get for people doing similar deviations of the protocol, we can then start to analyze that and understand. Anecdotally, a lot of them are having good outcomes as well with modified versions of the protocol. So, yeah, but we don't know that statistically yet. So we'll have to wait until we get a few more numbers to have the power to actually look at that data and those outcomes, and then we'll understand a little bit more. So that's one of the key considerations. A bucket handle meniscal tear, with mechanical locking, I think most of us agree that they benefit, or there's an indication there to undergo surgery. And so they typically go straight to the reconstruction route. But other meniscal tears, we had over 50% had meniscal tears in that paper, in the first paper of the first 80, and all but one were asymptomatic at the time the brace came off. So they'd recovered as well from that meniscal injury from that period of bracing.
Yeah, it's incredible.
So, yeah.
So is there anywhere people can go and learn physio specifically to become proficient at administering the cross bracing protocol?
Not really yet. We have resources available if someone or a clinic wants to start delivering this, to make sure they do it safely and to help out there. But if one of these trials gets funded, we'll be developing online training resources that clinicians can undertake that help them to learn how to deliver it as per protocol, and that'll likely be offered for free online. But we need the funding to kind of develop those resources. There's some people now undertaking some courses in Australia who want to deliver it, sports doctors and physios, but not at a global level yet.
Okay.
So, yeah, that's the thing, right? That's the question: is whether it's too early. Like, should we be encouraging people to do this yet? We don't have clinical trial evidence. So as a researcher, I'm a bit torn there, because I sort of say, ideally we have clinical trial evidence for anything we're doing.
Yeah.
But then I say, on the other hand, we don't have trial evidence for most surgeries that are being done.
Right.
And they have a much higher risk of harm, right?
Yeah.
And they're more invasive. So I'm kind of like, one thing I've understood is that patients want this treatment.
Mm-hmm.
We've received over 100 emails now from patients who've ruptured their ACL around the world and want access to this because they found the paper online.
Wow.
So I think as long as they're informed and acknowledged about the limitations in the research, the gaps and what we don't yet know, and then it's been done in a safe manner, then I think they have the right to access the treatment if that's what they want, acknowledging that we don't have trial evidence yet, and the knowledge gaps we have, like around long-term outcomes. We need longer-term follow-up and a lot of knowledge gaps there.
Yeah.
One thing, sorry, I will say one. Yeah. Sorry, one other point, because I think it's important, especially if physios are listening. With ACL injury, doing any non-surgical route, it's critical that you're avoiding knee instability and multiple episodes of knee instability. That's what we're trying to look for, and we're trying to flag, and they're the good candidates for surgery. those who don't achieve sufficient knee stability. You hear some terrible cases about people having 21 episodes of knee giving way, and then at that stage they go and see a surgeon or come back to the physio. So we need to make sure that we're monitoring and supervising rehab and then assessing and evaluating the knee function during sport-specific tasks under high demand, and then monitoring this person as they return to sport to make sure the knee's stable and they're not going to have any episodes of giving way based on the knee function and stability. Because at that point, you're really likely to damage other structures in your knee if your knee's just giving way all the time, the meniscus, the cartilage, and that's what we don't want. So yes, we're seeing less of that with the bracing protocol than with just rehab alone. But irrespective, that's what you're looking for, and that's what you're looking for as an indicator to refer to the surgeon if the knee's going to be unstable despite having undergone rehab or another non-surgical treatment approach.
Is there a timeline there? So after 1 month and there's been instances of the knee giving away, is that enough time for you to make that decision, or at what point do you call it?
Yeah, so it's a little bit circumstantial. So you have some people that say, I started rehab and then I thought I was feeling great, so I thought I was going to go play soccer after a month. And my knee gave way playing soccer. And you're like, oh, we shouldn't be doing that then. It was way too much, way too early.
Yeah.
Is that a reflection that knee is going to be stable in the long run? Unstable? Not necessarily.
Yeah.
But their knee's probably going to be in a worse position now because that instability episodes happened. They're the difficult situations. But if you're progressing through rehab and then people were at the stage of, say, taking an agility work and then their knee just gave way doing what it is that they had been doing, having progressed through those goals, then I'd question whether surgery would probably be a good option for that person. Still their decision, but I'd want to educate them that what we don't want is multiple episodes of giving way. So if that happens, then, you're either needing to modify your activity to avoid those kinds of tasks, which isn't ideal, or surgery. Considering surgery is probably a really good option to get that mechanical stability back.
Makes sense. Do you have a concern about the instability in the moment, even if it doesn't seem like there was a lot of harm in that moment, or is it more so that there's a risk associated with it? So I guess another way of asking that question is, if the knee is giving out, I think it makes a lot of sense that there's potential there for re-injury or to injure other structures. But if it gives out and there's no pain associated with it, are you very concerned with that instance of the knee giving out in isolation?
Yeah. Okay. So, what we're most concerned about is protecting the meniscus, because it is really implicated in osteoarthritis and knee function. You don't want a really damaged meniscus. Or a severely damaged meniscus. Protecting the cartilage, of course, is really important. And then even bone bruising and things could contribute toward potential OA risk. It's not a clear relationship, but it could do. So even if the knee's giving way, into knee valgus and causing someone to fall to the ground, you could also have bone contusions and bone bruising and things there as well. Yeah. But there's another kind of giving way where the knee kind of buckles, right, because of issues with muscle activation. So we know even with a bit of a fusion in the knee, a few millimeters, your quads are inhibited and your knee can kind of buckle, sort of, which someone might describe, it gave way beneath me. But it's not true knee instability as we consider from, an ACL deficient knee, like rotational stability or something like that. So kind of differentiating what actually happened in that instance is important as well.
Okay, thank you for that information. Because for me, I think I was sort of combining those two things, the difference between the knee giving away due to actual structural instability versus sort of it just buckling because of a neuromuscular issue. I think I was conflating those two things. So thanks for...
Yeah, that's a good difference. And we can see that, even with patellofemoral pain, right? And some other conditions, the knee can kind of buckle because of that quads inhibition and that fusion in the knee.
Right.
Yeah, so we would differentiate. But thinking about now, like, again, all the research we have around this knee giving way and how we've considered it a really important indicator typically to go and have surgery, we've been assuming that the ACL doesn't heal, but we haven't seen any, gross episodes of giving way in anyone with this grade 1 heel. So a normalized appearance or thickened at 3 months.
Mm-hmm.
So no episodes of just knee giving way amongst those people. So could it be that the sign of giving way is associated with the healing status? So these are people either with no heel or with a really elongated non-functioning ligament.
Mm-hmm.
And that's why their knee's giving way, and picking up on that, I don't know. Like, these are the things we don't now know, but will be so interesting to look at, I think.
Yeah, for sure. Especially, again, like considering maybe those populations that don't have easy access to MRI. Are there other things that we can look at based off of how they're presenting that may give some insight into maybe what's going on in their knee? I think that's really interesting.
Exactly. Yeah, super interesting.
Yeah.
Yeah.
Steph, I won't keep you here too much longer. Is there anywhere that people can maybe contact you or learn more about you or read your materials? Would you guide anyone?
Yeah. Yeah, sure. I think Twitter, or is it called X now? I'm not sure what Twitter X, whatever it's called. I'm on, and that's where we share all our research resources and our open access papers. So I'm at Steph Filbay. You can follow me there or contact me there. And we've also recently developed a patient decision aid for ACL injury management to inform patients of the pros and cons of undergoing rehab alone compared to undergoing ACL reconstruction. So that's a balanced evidence-based tool. That's a free online website. And it is quite different from the other information out there online at the moment, which tends to favour surgery and doesn't reflect the evidence. So that's available at www.aclinjurytreatment.com.
Got it.
So you can take a look at that. If you're a physio, you might find it useful as well, or you might want to direct some of your patients there so they can get their head around the evidence and then come in and have the conversation around their treatment options and what works best for them.
Mm-hmm. Cool. Okay. Steph, any final thoughts as we wrap up here?
Not really. I mean, well, one thing I'll say is that ACL injury is a lifelong condition, and I think we should think of it as that. And once someone ruptures their ACL, I think we should think of it as if someone comes to the dentist for their annual checkup to see how their teeth are going, that even once they return to sport, they think of it like that, and they get in touch, say, with their physio, and the physio can say, how are you going? Are you still playing sport? Have you had any issues with your knee? Any new injuries, any swelling, any pain? So we can detect signs of OA early, we can detect re-injury, and we can also detect people who are transitioning out of sport and are at risk of becoming inactive. And as physios, we can help them transition into another activity that they really enjoy. So I think just touching base with people in the long term and shifting the idea of the condition to more of a lifelong condition that requires some monitoring, some management, and touching base with a healthcare professional over time.
Wow, that's a good point. Maybe, on a 6-month or yearly basis or so, just having just a check-in with those old ACL patients. Insightful.
Yeah, and it could just be a quick phone screen, and if there's any issues, then they come in for an appointment. But it doesn't have to be, you don't have to be paying me each year, but it's just a quick touch base and see if everything's okay and you're on track. I think that would be really valuable to patients. Yeah.
Yeah, it'd be good to see the world go in that direction for sure. Okay, Steph, thank you so much. I think I'm going to have to listen to this again because it was just jam-packed with information. I appreciate you taking the time. I learned a ton, and I'm sure everyone else did as well. So thank you.
No problem. Thanks for the invitation. It's always great to talk about ACL injury management and research. So thanks for the opportunity.
Yeah, my pleasure. Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.